warm welcome and an Austrian service to our coverage from ESMO. The Congress of the European Society of Medical Oncology is one of the most important events in cancer medicine and took place in October in Berlin. My name is Claudia Altmann-Pospischek. I am from Austria, and for 12.5 years now, I have been living with metastatic breast cancer. I'm a patient advocate and blog under Claudia's Cancer Challenge. On behalf of patients today and the breast cancer magazine Mamma Mia, I am very pleased to be here today with one of the leading German women in oncology, Professor Dr. Nadia Harbeck, to take a look at important new studies that were presented at ESMO. Professor, would you like to briefly introduce yourself?
Yes, gladly. First of all, thank you very much for allowing us to do this report together. My name is Nadia Harbeck. I head the breast center at the LMU clinic in Munich.
We have taken a closer look at a few studies on metastatic breast cancer, which are of particular relevance from the patient's perspective, and now we turn to the HER2 positive subtype. And with that, I am happy to hand over to our medical expert, Professor Harbeck.
Yes, thank you very much. We have selected 2 studies, both of which deal with first-line therapy. That means when the disease has metastasized, the first therapy that we recommend to patients. One of the studies was about the quality of life data from a very interesting study, the PATINA study. PATINA was a study in which patients who received the first-line standard, namely a taxane-based chemotherapy with antibodies, for example, paclitaxel with trastuzumab and pertuzumab, could then, if they had received about 6 to 8 cycles and had a good response, if the disease had stabilized, they could be randomized for a maintenance therapy, specifically in hormone-sensitive HER2 positive cases. This maintenance therapy is usually done with antibodies and anti-hormonal therapy. And in this study, the CDK4/6 inhibitor palbociclib was included purely by randomization. So one group received anti-hormonal therapy, anti-HER2 therapy, and palbociclib, while the other patients received only the HER2 therapy and the anti-hormonal therapy. The focus was on how long the disease remained stable after the start of chemotherapy under this maintenance therapy. And we had the data we had already seen, and it was shown that by adding palbociclib, the CDK4/6 inhibitor, which is a standard therapy for HER2 negative hormone sensitive disease, such a CDK4/6 inhibitor was for the first time also used in the HER2 positive setting. It was shown that patients treated with palbociclib had a clearly longer period of stable disease compared to when only anti-hormone therapy with antibodies was given. In fact, this median progression-free survival of 44 months, we had never seen anything like that before in HER2 positive disease. So there is a lot of hope with this therapy. Unfortunately, it is not approved in this form, but in Germany, we can apply for it for individual patients with the insurance company based on the data from the PATINA study. So I have to say we've done this in Munich now, I think once or twice, and the insurance company then covered it for our patients. And what was now shown at ESMO was the quality of life, because whenever you change something in the therapy with the patients actually have a very stable situation for years. So you definitely don't want to worsen their quality of life. And here you can see these are questionnaires, standardized questionnaires that look at how the patients are doing, and then specifically also this anti-hormone therapy, which also comes with side effects, was examined again to see whether the well-being here actually worsens. And what you can see here with the blue bars, so to speak, is that everything remains relatively stable, not much changes, and that's a good sign, showing that the quality of life remains very, very stable here, despite a significant extension of the time that patients spend on this therapy without disease progression can spend with the disease. And here you can also see this again for the course of quality of life up to the first progression. And you can see that it's actually relatively comparable in both study arms. That means we have a therapy that extends the time until disease progression by more than a year on average. So in total, 44 months, that's almost 4 years. And yet quality of life remains completely stable. That means palbociclib actually doesn't have much of an impact on quality of life. We have known this substance for a long time. It causes changes in blood counts. The patients don't feel that. You just have to adjust the dose, and then it actually works very well. So I think this is a new standard of therapy in this maintenance treatment that is for stabilizing the therapeutic effect after the initial chemotherapy. I really hope that the company will apply for approval here. And until then, we have to make individual case decisions for patients who respond very, very well to the initial chemotherapy and discuss these individual case decisions with the health insurance providers.
Thank you very, very much. Just one comment from me. For me, the key statement here is palbociclib extends the time without disease progression by 15.2 months and overall by 44 months. And in our modest situation, that reads as an enormous amount of time with loved ones, time for everything that matters. And I can add from my own experience that I had an excellent quality of life for a full 6 years with palbociclib. That's just my personal note on the matter. Thank you very, very much, and we'll move right on to the next study, HER2 positive. Thank you very, very much.
Yes, this is also about first-line therapy, specifically a new first-line therapy. Also, here we had already seen data at the major American Cancer Congress in May and June of this year, the Destiny Breast 09 study. These are patients whose cancer has returned with HER2 positive disease who have not yet received any further therapy for this metastatic disease. And Professor Lubel presented additional data at ESMO on various subgroups of patients where, as a clinician, you want to know whether it works just as well there. This is about the antibody drug conjugate TDXD. It was either combined with placebo or with pertuzumab. We know pertuzumab as a combination partner for trastuzumab as well. And the standard arm was a taxane with trastuzumab and pertuzumab, the so-called Cleopatra regimen, which has been our standard in first-line therapy for over 10 years. In total, almost 800 patients were enrolled and randomly assigned to the treatment arms. TDXD is an antibody drug conjugate, a further development of trastuzumab, where a chemotherapy is delivered directly to the HER2 positive tumor cells using trastuzumab as a targeting agent. This compound is our standard in the second-line treatment of HER2 positive disease. And now the question is, does this also work in the first line? Does it matter whether it is a first diagnosis with metastatic disease or a recurrence after previous breast cancer therapy? What is the hormone sensitivity of the tumor cells? And is there a so-called PIK3CA mutation? This is a mutation in the signaling pathway that can also confer a certain resistance to anti-HER2 medications. Professor Lubel and her team have looked at all of this, and here you can see again what kind of patients were included here. About 50% had hormone receptor positive tumors. And in half of the patients, and I think this is already quite important, it was a de novo disease. That means the patients had no previous breast cancer diagnosis, but instead presented directly with metastatic disease. We see that in early stage HER2 positive carcinoma, we are already able to cure many, many patients. And that's why worldwide, those who present with metastatic disease are, in general, for the most part, we are talking about patients whose disease was already metastatic from the very beginning, meaning their cancer had already spread at diagnosis. What has been shown is that TDXD with pertuzumab, that is the antibody drug conjugate, is superior in every respect to the standard therapy. And so, of course, we also expect that this will lead to an extension of the approval. Here you can see the data again, which we already saw at this year's ASCO. The time to progression is significantly improved. Here we see a median of 40 months with TDXD plus P versus 27 months with the previous standard. And then if you look at this, Professor Lubal was able to show at ESMO that this was independent of whether this signaling pathway was altered, whether there was a mutation in the PIK3CA gene, whether the tumor was hormone sensitive or whether it was a new diagnosis. All of these subgroups, the benefit of TDXD plus P was the same in all subgroups. And so you can To summarize, the study did achieve its primary endpoint. The therapy is effective regardless of disease history, hormone receptor status, or PIK3CA mutation status. There were also no new safety signals. We are familiar with the substance and have already worked with it in many ways. So I would think that TDXD plus P could become a new standard therapy here in first-line treatment. As I said, we have to wait for the label extension, and we are currently looking in a new series of studies worldwide to see whether we really need to continue TDXD plus P for such a long time, because of course it also has chemotherapy side effects, or whether it might be sufficient to treat until the best response is achieved and then continue with antibody maintenance therapy. The substance is already available as part of studies in first-line therapy, either in the Demeter study or in the Top Reel study, which is set to start at the beginning of next year, so that in individual cases one can participate in a study.
What fascinates me is that the therapy works regardless of the disease history, hormone receptor or PIK3CA mutation status. That sounds, in my opinion, very promising. That sounds very, very good to my ears. Does that mean that in the future, many HER2 positive patients will benefit from this combination?
Yes, so I think this substance has been such a breakthrough success that we will then use it very broadly for HER2 positive carcinoma. And as I said, the studies I mentioned are simply addressing the question, do I really have to give it for 2 or 3 years? With all the side effects, it can also cause a certain fatigue. Or is it enough if I treat until the best response is achieved, maybe 6, 8, 10 times, and then simply do maintenance with antibodies? Then we're back to the topic of maintenance therapy from my first lecture on this subject. And of course, you could take it a step further and say that in hormone-sensitive disease, maybe I could use palbociclib again. So there's a lot happening right now in HER2 positive disease. I think the message is we have a lot of options, and these options are becoming increasingly effective.
A lot is happening in this area, and that's exactly what we love to hear. Yes, and even though metastasis is, of course, a heavy burden to bear, these new findings sound like a path that can be managed better and for longer, like more lifetime and quality of life. And of course, we are always happy about research and development because we as patients benefit enormously from it. Thank you very much for your clear and understandable explanations, dear Professor Harbeck. Your remarks give us courage and hope, and that is exactly what we need. And with that, we have reached the end of this HER2 positive blog from the ESMO coverage, and I thank you for joining us. Thank you very much.